Welcome back to PedsCrit. I'm Zach Hodges, a pediatric intensivist at the University of Texas Southwestern in Dallas.
And I'm Al Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
And we are so excited to be sitting down with Dr. Tobias Straube today to discuss exertional heat stroke. Toby, will you please introduce yourself to our audience? Tell us who you are and what you do.
Hey everybody, my name is Tobias Straube. I'm an assistant professor at the Duke University School of Medicine in the Division of Pediatric Critical Care Medicine, and I'm attending in the pediatric ICU. I do most of my work clinical, but I also do some research on the side. Thank you guys for having me on.
Yeah, well, thank you for joining us. And now, if we're counting correctly, it looks like you're in your 4th year as a PICU attending?
That's right, yep.
I'm wondering if you have any words of wisdom as we go from early career to mid-career. What kept you productive and doing well in early career time?
I think the humbling nature of our work kept me productive in that I was always striving to improve and be better and continue to read more about my patients. I'm sure this is rather cliche, but really those first couple years out from fellowship is when I learned the most, when the burden of responsibility fell upon my shoulders to take care of these patients. And that pushes you and makes you better. And now as I'm transitioning to, having a couple years under my belt, I would say I'm feeling more comfortable in my practice, but you're always learning. Yeah. And I think that's one of the joys of our profession and job.
No, that's great. I mean, me now in my 2nd year, when I just reflect where I was even a year ago, like how much growth continues to happen. And it's fun. I even just got off a call with interviewing a graduating fellow for a position here. It's so wonderful talking with them. I know it's going to be so difficult, but it's going to be so great, and just keep working hard. As we get into our topic today, exertional heat stroke, any conflicts of interest to disclose?
Yeah, I should mention I'm also the chief medical officer at VQ Biomedical. This is a startup that I spun out of Duke. It came out of my research in doing high efficiency membrane oxygenation. We're working to develop a intravascular oxygenator catheter, but nothing that we're going to talk about today overlaps with those efforts.
Wait, that's very cool. And now I don't want to ask you about heat stroke. I guess we can, but I have questions about the intravascular oxygenation for sure.
I'd be happy to chat about that at any time. That's one of my passions for sure.
Well, going back to heat stroke, let's get things started with a case. All right. So we're going to give you a 15-year-old boy admitted to the ICU following collapsing at practice. Ambient temperatures were in the mid-90s Fahrenheit with high humidity. In the field, his core body temperature was found to be 40.5 degrees Celsius or 105 degrees Fahrenheit. He was cooled by EMS, and this continued in the emergency department. His body temperature is now normal, but he has persistent altered mental status. He's protecting his airway, and you've got IV fluids going, and a Foley catheter in without much urine output. So we've sort of given you a lot here. Before we get into this specific case, what is exertional heat stroke?
Yeah, so first let's define heat stroke, and I think we can kind of subdivide it into the various exertional and classic heat stroke. So heat stroke is life-threatening emergency that occurs when the body temperature exceeds 40 degrees Celsius due to environmental heat. Physical manifestations essentially always include a central nervous system abnormalities, and these patients can present with a surge response and shock, cardiovascular collapse, and ultimately progress to multi-organ dysfunction. This can further be subdivided into exertional heat stroke and classic heat stroke. So to answer your question, exertional heat stroke, develops in the setting of exertion, whether that's recreational or occupational exercise. And it results from heat production from the muscular work, and that heat from your muscles exceeds the body's ability to dissipate it. Contrast that to classic heat stroke. That's when the high ambient temperatures around the body are enough to overwhelm the normal physiologic responses to cool the body. So I think of exertional heat stroke is really the heat comes from within, whereas classic heat stroke, the heat comes from the ambient temperatures. Now, obviously, exertional heat stroke happens more commonly when there's also hot temperatures outside, and we can get into that in a little bit.
So we have this dichotomy of classical heat stroke where it's almost certainly primarily from the environment. Perhaps it would be a child who's like in a warm vehicle that was turned off. And then we have that contrast that with exertional heat stroke, which is, I assume, commonly in this hot environments, humid environments where there's activity happening. What else would you overview as being like the important risk factors for development of heat stroke in children?
Yeah, I think in general, little ones, so children under the age of 2, are higher risk because they are inefficient in their ability to cool themselves. Neonates and infants, of course, are at the highest risks. They poorly develop thermoregulatory mechanisms, and they're really completely dependent on their caregivers. So if someone accidentally leaves a neonate or infant in a hot car, for example, they can't do much about that. Children with developmental delay or intellectual disabilities would also be at higher risk because of potentially poor judgment or their inability to remove themselves from environments. And then I'll say adolescents are particularly at risk for exertional heat stroke. Obviously, that's adolescents who are playing sports outside, and there's quite a bit of that. There's also a group of adolescents, who get heat stroke that kind of fall into a category of teenagers making poor decisions, maybe recreational drug use, and that leading to situations where they're exposed to higher heat than they otherwise normally would have been.
It seems like if perhaps an adolescent was taking a stimulant or perhaps an anticholinergic medication where they couldn't perspire as much, that would be a risk factor for heat stroke. When I was getting ready for today's conversation, I learned about this heat acclimatization process that even colleges and high schools go through to get kids ready for activity in the warm part of the year. Will you tell me more about, what this process looks like and how effective that might be for preventing things like heat stroke?
Yeah, great. I'm not sure the exact data on how effective it is, but there's some evidence that prolonged acclimatization, so I'm talking weeks, not just a couple days, but weeks, can lead to some physiologic changes that protect individuals a bit from developing heat-related illness. So a couple things that can happen. Over time, if folks are kind of slowly exposing themselves to warmer temperatures or this acclimatization period, they can have their sweat glands develop to increase the capacity to sweat, which of course is important for evaporative cooling. Their plasma volume will increase. This can help with this increased blood volume. When there is cutaneous vasodilation, it can help with heat dissipation that way. The renin-angiotensin system is also activated, which then leads to salt conservation and, again, plasma expansion, so on and so forth. But, these are physiologic and hormonal changes that take really weeks. So I think the key with acclimatization is that it's going to take a couple weeks of slowly increasing your exposure to warmer ambient temperatures.
Oh, that's interesting. I didn't really know that sports teams did that. Smart.
Toby, you've already mentioned your link to Texas, and something that I knew before moving to Texas and have been reminded of, just the love for high school football. And you can see the pitfall here, right? Perhaps the player, the participant is at home during the summer, and then August gets here and football practice gets started. It would be an incredibly high risk time if there wasn't that multiple week lead in where getting used to perhaps the hot weather, practicing, putting on pads and kind of reviewing some of those protocols. It looks like there can be potentially increased safety from, doing practices without pads and then doing a staged approach where you're slowly increasing the strain on these kids.
Yeah, that's exactly right. And I think these trainers and coaches are certainly becoming more aware of heat-related illnesses in general and prevention. And so I think their programs incorporate this kind of slow buildup. And if I'm reflecting back to my experience growing up in College Station, Texas, I remember there was a summer where it got to 113 degrees Fahrenheit, and the football team went out and practiced in the morning, as they always did. And they made T-shirts saying how tough they were. And in hindsight, not a great situation. And I would say today that would not happen and that would not be celebrated. And I would think that's a step in the right direction. Prevention is the best here. Prevention is the best to avoid the pitfalls of these heat-related illnesses.
Oh, absolutely. So let's get into what actually is happening to these kids. What are the early signs of heat-related illness?
Yeah, so it's a spectrum, and someone put names into these kind of buckets of symptoms, but again, it's kind of this continuous spectrum. So first, heat cramps. So heat cramps are painful muscle contractions that are developed with heat illness. At that stage, the patients might be thirsty, might have some dehydration, but simply getting them out of the sun and into the air-conditioned environment is enough to get rid of that, and there's really no long-term effects. Then next comes heat exhaustion, and that's a bit more serious. Now the person's going to have headaches, intense thirst, weakness. They'll be nauseated, dizzy. their core temp is probably still normal or maybe elevated. So this is kind of when you're maxing out your physiologic cooling mechanisms. And then as soon as you cross over that threshold where your normal cooling mechanisms are overwhelmed, that's where your core temperature is going to rise and quickly. And that is when you hit into heat stroke. So early recognition is key because you can turn things around quickly from removing, the patient or person from that environment.
So what I'm gathering is that there are mechanisms in place to prevent that core temperature from rising above the normal set value. And as long as that's maintained, it seems like neurologic function should be preserved. Will you tell me more about, what does that threshold look like when we actually start calling a patient having heat stroke? What are the manifestations we look for?
Yeah, so I think that threshold is when the core temp is above 40 degrees Celsius and there's any central nervous system involvement. The neurologic system is really kind of a cardinal and early sign of actual heat stroke when you have crossed that threshold. And now it's a life-threatening emergency. And that neurologic impairment can be, again, it's also a spectrum. It can be someone who's just a little confused, maybe slurring their speech, impaired judgment, acting disinhibited, or it can be, it can progress quickly to frank delirium or, someone can lose consciousness even.
Oh, wow. So if you guys were at the sideline of a game or something and it was concerning to you, the first step would kind of be talking to the person and seeing if their mental status was normal or abnormal.
Alice, I wanted to add, this seems fraught with issues, right? Because let's just envision the football player who's perhaps going to two-a-day practices for the first time, and perhaps they just had a big hit, a big tackle, and maybe their bell was rung a little bit, and all of a sudden they're acting a little loopy. No, seriously, I know it's so funny to say out loud, but you're describing subtle signs and altered mental status might be the first sign, right? And there are so many reasons, some sinister, some not as sinister, for an adolescent to, quote, not be acting right. And it's something that we have to be incredibly careful with.
Yeah.
Yeah, I think you need to be vigilant. Now, it's altered mental status in the settings of some of these other markers of heat-related injury. They probably are having heat cramps, they're describing thirst, they're looking dehydrated. So I wouldn't say it's totally just isolated neurologic signs. It's amongst the background of some of those other symptoms. But yeah, without a doubt, it can be, I think, super confusing. I think that the high school football player, that's the classic case, and you have to be particularly vigilant. That needs to be higher in your differential.
Yeah. In the context of the bravado that you've already mentioned about always pushing through and always, not stopping when the pain is happening.
Yeah. So once you've identified this in the field, what are the best practices for early treatment?
So I think you just summed up the best practice with early treatment. That's relatively straightforward. So if you've crossed that threshold to heat stroke, then yes, it's life-threatening and we need to immediately intervene. So step one, ABCs, like we always do, airway, breathing, circulation. Let's assume those are intact for this moment. Then rapid cooling and establishing IV access and beginning fluid resuscitation. Rapid cooling can look like different things, but in exertional heat stroke, it should look like getting some ice water and applying it to the patient all over as quickly as you can. If there's an ice bath nearby, as sometimes these training facilities have, it's time to put them in their shorts, boxers, and dunk them. If there isn't, one thing that I kept reading about in the emergency medicine literature and pre-hospital literature is the tarp taco, which I thought was just lovely. Literally, EMS or others will have a tarp and they just throw a slurry of ice water in there and just wrap them up. Of course, remove the clothing. So you want to get as much ice water in contact with the skin as possible. Importantly, putting ice on the neck, the axilla, and the groin, where you think there's a lot of blood flow and those are kind of warm areas. Nope, that doesn't do much. In heat stroke, you've got large majority of your blood flow is now going cutaneously from the vasodilation because that's an attempt to cool. And so you need to put ice where the blood is, and that's all over the skin. So you need ice water in maximal contact with the skin, and you need to do it fast. With regards to fluid resuscitation, getting an IV early, establishing a couple large bore IVs, and getting some crystalloid fluid resuscitation is going to be helpful. Fluids obviously can cool a patient, but not really that much. A liter of fluid, even if it's like a cold liter of fluid, is only going to drop the temperature minimal in like an adult-sized patient. So I don't really think of it as cooling the patient, but without a doubt, it'll improve organ perfusion because these patients will be likely dehydrated and kind of in a high output state. And expanding the intravascular volume will improve that blood flow to the skin, which then will help cooling, especially if you have ice water all over that said skin.
I like the emphasis on using immersion if possible. And if you can't have you don't have an ice tub, maybe that tarp taco where you're just enveloping the child in a plastic wrap with ice water in there. You would think if you don't have access to that, maybe water sprays with fans could be another reasonable option. Assuming that you're able to monitor this child's temperature during the cooling process, what pace of cooling would you generally target? And then I guess where would you stop cooling them? Surely you wouldn't put them, below 37.
Yeah, great. So couple points. With the alternative method of cooling, like you're saying, spraying with some cool water, applying cold, wet rags, that definitely can work. It's not as fast as ice immersion, but it's way faster than just like putting someone in an air-conditioned room. Putting water, even if it's just cool water or ambient temperature water, is so far superior than just putting someone in a conditioned room because of the evaporative heat loss that happens with applying water. And so I want to say that, yes, that is a good method. And then the pace at which you cool, honestly, I don't care too much about the pace because your ability to monitor that carefully, like in the field, is going to be questionable at best. Try to get a core temperature if you can. Rectal is going to be best, I would think, out in the field. But you just need to cool as quick as you can. And if you put someone in an ice bath, then you're going to cool them, about 1 degree Celsius every few minutes. And that's great. If you're not in an ice bath, it's going to be something slower than that. There is almost no situation that you can cool them too fast. Now, you can cool them too much. So to your point, I think once the temperature is kind of approaching more, quote, human temperatures, normal body temperature being 37. So I'd say once you're like 39 and getting into that 38 range, that's when you stop active cooling. You certainly don't want to make them hypothermic because then you open a whole new can of worms. And there's no data for, overshooting and hypothermia being somehow protective in these patients. And so you definitely wouldn't want to do that.
Oh, that's interesting. When you look at the literature, it sounds like the cooling process, if they had the resources to do it well in the field, might be pretty fast, right? Like by the time they're in the ED, the insult has happened, you've cooled the patient down, and now you're just managing the collateral damage.
That's exactly right. So do the math. Let's say they're 40.5, like our clinical vignette here. If you cool them by about 1 degree Celsius every 3 to 5 minutes, in 20, 25, 30 minutes, they should be done with cooling and closer to physiologic body temps. And so there's 2 important points. Fast is important and early intervention. And then the second point is when they'll present to you as a critical care physician, or if you're in the emergency department, or just let's say they go to an urgent care or primary care, they may have heat stroke, but have a normal body temperature. And I think that could be confusing. We're taught in med school the history is everything. Well, the history then would paint the picture, right, of heat stroke. But your physical exam with a normal body temperature at that point may be counterintuitive.
In other neurologic processes, perhaps like traumatic brain injury, we get really worried about hyperthermia. And it's even part of many protocols to have scheduled antipyretics for kids. What's the role of antipyretics in heat stroke? Is it something we should be doing, or is it fraught with some issues?
Yeah, I'm glad you are bringing that up. It's fraught with some issues. We shouldn't use them, particularly acetaminophen, salicylates. They can be harmful because they can, aggravate coagulopathy or, liver or hepatic injury, which is part of the multi-organ failure in the later stages of heat stroke. Independent of that is they just don't work. In terms of antipyretics, they normally work by resetting the hypothalamic set point to tell the body to retain heat when you have a fever. Well, in heat stroke, the set point is not the problem. The body is trying desperately to cool the body, but those normal physiologic cooling mechanisms have failed. And so A, they won't work, and B, there's harm. So do no harm. Don't give them. I will say there was some literature when I was doing some reading about this that questioned the use of dantrolene in some children who have severe heat stroke and you're having difficulty cooling them despite the methods to cool them, that dantrolene may be okay. And I'll say, I guess that makes sense from like a mechanism of action standpoint. Dantrolene works by blocking calcium release in the myocytes, and so the myocytes can't contract. And so you can take that muscle heat generation out of the equation. So I would say maybe in the patient who's still really hot despite your attempts to cool them and they're, kind of rigid, shivering, maybe, but I wouldn't routinely recommend it. That would be like a kind of a last resort adjunct. So maybe dantrolene, but other antipyretics, no, I wouldn't use them.
Nice. Now, we've given you a patient here. Something happened at football practice. He got up to 40.5 degrees Celsius. Now he's maybe direct admitted to your unit, and you're kind of looking at this guy, and he is maintaining his airway, can't talk to you, something's going on. Can you outline what we expect to find when we investigate what's going on in his body and sort of the phases of heat stroke that we expect?
Yeah. So you can break heat stroke into, I would say, 3 kind of distinct phases of the natural kind of progression of their course. So there's kind of the immediate phase, which is the hot phase, the hyperthermic phase that's coupled with neurologic abnormalities. This is, like I said, when they're hot, albeit if EMS did their job well, they may actually now have a normal body temperature, but they're still altered. Their mental status should be improving if they're cooling, but that's that immediate, the injury just happened. Then the next phase is kind of in the 24 to 36, 48 hours after, and that's what folks describe as the hematologic enzymatic phase. And really that's where your series response happens. You have hyperinflammation, you have an acute phase reactance, cytokines kind of storming, that leads to endothelial cell activation, and kind of there you go to kind of your coagulopathy. So both, fibrinolytic and coagulation cascades are activated, leading to consumptive coagulopathy, which then hurts the other organs. And so that phase lasts a day or two. That's the SIRSy phase. Some patients will recover out of that, but patients who have a severe heat stroke phenotype will progress to the late hepatic renal phase. And that's days to weeks after, where there's end organ damage. There's acute kidney injury, acute liver injury that has happened from a combination of blood being shunted away from those vital tissues and organs to the skin as the body was trying to cool. Then there's some microvascular congestion from the possible DIC that the patient has seen in the second acute phase of heat stroke. And so, it's a multifaceted disease. It's not just someone's hot and then they're cooled. There is physiologic consequences. There is cellular injury in organs, and it's a real problem.
What I'm gathering is that heat stroke is a multi-organ system illness. And even if organ dysfunction isn't present right when that child presents to care, that's not to say it won't develop. And these kids need close monitoring. And if they have evidence of neurologic injury, we should suspect they're going to have other organ systems to be injured in the hours to days coming.
Yeah, that's a great summary of kind of how you should wrap your head around it. Absolutely.
Yeah. Is it true that a lot of these kids end up with like a liver failure phenotype?
I think there is a high incidence of liver failure because the liver itself is such a metabolically active organ. It actually is like a heat sink. It generates a lot of heat. And the hepatocytes itself are just very fragile to heat. Think about all the enzymes occurring in the hepatocytes as it's trying to, metabolize things and such. And we're going to go way back to biochemistry, right? These enzymes are proteins, and at various temperatures, the protein folding is just messed up, and then they just don't work. They don't either catalyze the reaction right or so on and so forth. And so the liver can undergo a severe injury from heat exposure. Absolutely.
Leaning into the coagulopathy piece, and feel free to critique me if maybe my mental model is not correct, but kind of how I see it is that you have this child who gets very hyperthermic, and then you have all of the coagulation factors in their bloodstream perhaps get cooked, if there's not a better way to say it, and they become inactive. And then you have the liver injury, which as we in our reading, we found that like perhaps the liver is even the warmest organ in the body because it's central location and all of the activity happening there. So then you get liver injury, you have the inability to replace those factors, and it's just a terrible setup for terrible bleeding coagulopathy.
That's exactly right. And one thing that was interesting that I learned as I was preparing for this too is when you cool a patient, it can mostly reverse the fibrinolytic system abnormalities, but the procoagulant enzymes are then still abnormally active. And so it's a net hypercoagulable state after the fact. So yeah, it's just a mess. It turns out we evolved to operate at 37 degrees Celsius for a very important reason, and that's all our enzymes that are important for our normal vital functions work best at that temperature.
Yeah. That's interesting because we've given you a patient who's only 40.5 degrees Celsius, right? But he has neurologic injury, and I'm hearing that he can have severe multi-organ dysfunction on presentation or over the next 72 hours. Only from 40.5?
Yeah. Although that's hot. That's what, 105 Fahrenheit? I mean, it is hot.
Yeah. But if a parent calls my primary care husband with a fever of 105, he's asking other questions, but he's not worried about acute organ dysfunction, right?
Yeah, without a doubt. I think the difference from a fever and from like a heat-related illness is that, with a fever, the body is making itself raise the temperature to that, and there's a ceiling. And how many fevers have you heard of above 105? Not too many. With heat stroke, the body is desperately trying to cool itself. As it is doing that, it's shunting blood away from the vital tissues and organs, so they're now more susceptible to injury. And the other thing is there's no ceiling, right? The temperature can just keep rising. And once they're unable to cool themselves, the temperature will just go up. And if the patient was measured at 40.5, that's probably at the time when they collapsed. Might have been 41 earlier.
Right. I think the key theme is this dysregulation to the increase in temperature with heat stroke as compared to fever.
That's right.
So kind of honing in on the neurologic injury here, we've kind of already described the clinical manifestations are those of like a diffuse neurologic injury. You've kind of described like what it might look like delirium or altered mental status. If we were to perhaps like get imaging on this patient, or would we expect, diffuse findings, or are there particularly focal injuries we might find? Tell us a bit more about the neurologic pathology here.
Yeah, so I think there's a couple things. There are some areas in the brain that are more susceptible. The pyramidal tracts and the cerebellum is a little more susceptible. So you may see that on, something like MRI. But you could also, in severe heat stroke, progress to frank cerebral edema, and then that would be a more global phenomenon. So it kind of depends. I would say there's not really a role for MRI imaging in the early stages of heat stroke. You just need to treat the patient. And if they have neurologic abnormalities, that means, it's a severe phenotype, it's heat stroke, and get ready because other organs may start falling apart too.
So maybe thinking more about the multi-organ system disease here, we've already mentioned coagulopathy and liver injury as being two common complications here. What are the other organ systems that tend to be harmed quite commonly in exertional heat stroke?
Yeah, so in exertional heat stroke in particular, this is a presentation where there's severely dehydrated, so they're going to be volume down intravascular. That'll make them kind of susceptible to a pre-renal acute kidney injury. But also in exertional heat stroke, by definition, they were vigorously exercising using their muscles. Their muscles were hot, and now everything's way too hot. That leads to direct myocyte necrosis and injury and spilling of myoglobin into the bloodstream. Now you have rhabdomyolysis, which gunks up the kidneys further. So I think AKI, rhabdo, you can see hyperkalemia from this muscle breakdown is quite common. It's not uncommon that these patients would need renal replacement therapy to help mitigate, some of the harms from that. You can also see, cardiac involvement. Obviously, hypotension from both like a hypovolemic shock from dehydration in exertional heat stroke, but also almost like a high output heart failure. The heart is cranking, create a high cardiac output to flow the blood to the vast network of vasculature in the skin to try to dissipate heat. That can be hard. So you can have cardiovascular effects as well. And then we already touched on the liver injury and the coagulopathy that's seen.
So it seems like any kind of organ system can be affected. And I would not even be surprised if ARDS could develop.
Yeah, that's right. There is kind of phenotype of ARDS described in the literature, in that 24 to 48 hours after the initial presentation.
Oh, yeah. What about when we read about the pathophys of liver injury, there's this theory that it's gut translocation and then those bacteria go into the portal vein. What do we know about the infectious complications?
Yeah, so I would say the infectious complications aren't a huge part of heat stroke, but there is some, concern that there's a hit to the normal gut barrier. Again, during the initial phase, blood is, shunted away from the gut, the splanchnic circulation. And so if the gut takes a hit, particularly in the patients who get DIC and they have microvascular congestion of the splanchnic vasculature, you could get, epithelial breakdown of the gut barrier and translocation of bacteria. I don't think of that as like a main kind of central thing when I'm treating my heat stroke patients. I would more think of them as any critically ill ICU patient being susceptible to infection, just no more so than others. But keep in the back of your mind, their gut took a hit and they could be translocating. Put it this way, I wouldn't empirically start them on antibiotics.
Excellent. Okay, so I'm hearing about the multi-organ dysfunction. The insults happened. You're expecting cerebral edema, you're expecting DIC, you're concerned about the liver and kidneys. When you really looked through this literature, how do these kids end up dying? It's awful to think about, of course, but is it circulatory failure or do they end up like herniating a few days later?
I don't know the answer to that. My best guess is nothing more than a guess, but I think it's going to be just from multi-organ failure. I don't think it's going to be cardiovascular collapse. I think we can stabilize and get him through that, but it's going to be end organ dysfunction and the sequelae of that.
No, absolutely. And that does sound like a sepsis death, right? Like the multi-organ dysfunction and not necessarily this happened, cerebral edema. Oh, this is going to be a few days, but we worry about herniation first.
That's right. Particularly with cerebral edema. I don't think that's how these patients die.
Yeah.
I feel pretty comfortable saying that. It's a combination of the multi-organ failure and just a downward spiral thereafter.
Nice. Yeah. So kind of reflecting on our conversation, like pearls and pitfalls of taking care of these kids with exertional heat stroke, it seems that early recognition, early treatment with cooling, and then close monitoring, because organ dysfunction can develop even if it's not present when they're presenting to the emergency department or to your unit for the first time. Any other pearls or pitfalls that you'd like to emphasize as we move towards the end of the day's conversation?
Yeah, I think I'd like to add that prevention is probably the best management to heat-related illness, especially with regards to exertional heat stroke, especially in the pediatric population, because these are basically or often sports, or adolescents playing sports. So I think with better education to coaches, trainers, school system staff, sports teams, we can prevent a lot of harm. And so I think that's important, especially as, there's more and more heat waves, there's climate change. We're seeing this more. I expect all of us in our practice will continue to see this more as the years go by. So we ought to aim to prevent it. The other thing I'd like to highlight is be vigilant. Pediatric patients who present to your care, whether that's in the emergency department, urgent care clinic, or obviously in the ICU, if they come in with undifferentiated shock and altered mental status, that could be due to heat stroke, even if they have a normal body temperature. And so be vigilant. And then, I just want to reemphasize, key to management is early recognition and cool right away. Don't try to pack up the patient and bring them to an ICU. Cool them on the scene en route.